I think it's a fair place, isn't it? I was just reading a post this morning about the art and science of medicine, and I think it's a great place for us to sort of unpick that, Roger, today on where we think the art has been lost in the pursuit of science and being very certain, isn't it?
Yeah, I mean, gosh, that's there's all sorts in there, isn't there? And the litigation and the regulation is all important to mean that we have to have some kind of structure and framework, and that's right and proper. But there's some dance around allowing the individuality and the art of what we do. So we were chatting before we came on about the diagnostic label, and how it's useful, but it's a double-edged sword, and that the traditional training for both of us, either medically or in the physiotherapeutic world, we go through a subjective and objective and history taking, and we arrive at some conclusion of, I think it's probably this, and we call it whatever it might be, rheumatoid arthritis, we call it fibromyalgia, we call it whatever. Now, and then that opens the gateway to the form of intervention, drug or physical therapeutic intervention that we use, or psychological interventions. Well, that's kind of useful. Yeah. We go, right, okay, well, I've got this, I've excluded that, big toe's inflamed, it's got this pattern, blah, 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 uric acid levels are 600, right, okay, give them allopurinol, you've got gout. And that's okay. Things like fibromyalgia are a diagnosis of exclusion, where it's like, well, everything else is sort of checked out okay, or the chronic pain patient of, well, that's checked out okay, and that's checked out okay. And then we end up with all of these functional things back in the sort of, functional problems in the old psychological models, which basically was medical code for, I haven't got a clue what's going on. And I've excluded all the serious pathology, and then you'd get all these awful things where they go, well, it was in your head. The art for me is around being able to evaluate the person, meeting them exactly where they're at, and rather than assuming that there's any labelable diagnosis other than what is going on and dysregulated within their system right now. So that as you notice something going on, you think, right, well, I am noticing this. I am noticing the skin. I am noticing these different labels that they might have. They've got some disturbance to their bowel activity. They've got some change to their skin. We've got some history here of what's gone on in their life with the divorce or some bereavement or something. And then we go into the early years. And then we go, right, and actually they've also got pain here and it behaves in this way. And when we start to actually assess these people, moment to moment watching what's happening, and we get good at really reading what's happening to their physiology, to their energy field, to the sense of the emotional quality with the interaction, then there's this unique, beautiful picture which is painted before our very eyes. And it doesn't really have any diagnostic label other than that is what is happening for you right now.
Not yet, isn't it? And I don't think we'll ever really come close to that bit. For example, and I think a lot of that has to do with how we are taught in our individual schools of thought. For example, with the mainstream medical education that I grew up in India in sort of the 90s, and for the matter, when I came here to the UK as well, what I saw was being taught in the medical schools, all the trainees who would come to train with me and alongside me, we are very much almost taught that there has to be a reason for a diagnosis. Everything that we do in those 5 to 6 years of medical school is, these are a set of symptoms. If a person has these sets of symptoms, this is the first most likely diagnosis. And you could have a couple of differential diagnoses, but like you said, everything was in pursuit of trying to find a neat box to put people in, so that that box automatically had a set of treatments, often which involved drugs or surgery. and then something else. And I think this is the model on which we were all taught in the 80s and 90s, probably even into the early sort of noughties. And that effectively means that conditions like fibromyalgia, which has had its share of names, from when I used to look at the literature of what it was called in the 50s and 60s and 70s, because you presented with pain, and at that time pain was always thought to be due to an inflammation, which means an itis has to be applied. So it was fibrositis because it happened apparently in the fibers. Then they thought it would be muscle, so it is myositis. And somewhere along the way in the early 90s, they said it is fibrous and muscle, so maybe it is fibromyalgia, which meant there was pain but not necessarily inflammation. And that is still a prevailing concept even now, even though we've got fairly decent information that the immune system is involved, the nervous system is involved, what you talked about, what early experiences might be involved, how a person's context, seeing the whole person, you can get a much better tapestry of the information and the person in front of you. All of that is really art, and because that cannot be codified, that cannot be put into a neat box, and if it's not put in a neat box, managers of organizations cannot say that this needs this much of money coming from a certain payer. We always end up losing the artistic aspect of diagnosis, or rather treating, and he sacrifices it towards putting them into neat boxes that fetch you a certain pot of money, and there are defined evidence-based treatments that will be offered and that will be paid for. And I think that is a constant challenge I find, not just with conditions like fibromyalgia is one typical example I've seen changing, but you find that with so many other pain conditions and sort of trauma-related conditions that we are dealing with now. I think that is requiring us to have a real change in how we do healthcare, isn't it? If especially the last few years now with the rise of some of the things that we are interested in, that requires almost a change in how the system pays for the kind of good care that we do, which doesn't get recognized in your traditional diagnostic boxes.
No, indeed, and as you speak, I'm thinking here we are, the very current topics of the reforms within the National Health Service right now, and I'm heartened that they are at least giving some, albeit a little bit lip service perhaps, but we'll see, they're giving some attention to social services as being part of the reforms of the healthcare provision in this country, and I think that that's really important. I'll tell this thing because it makes the point that I can remember some years ago a gentleman, a patient that I was treating, very interested. He was a head teacher of a primary school and was very aware of ACE scores and the adverse childhood event scores that we've spoken about before. And, in our sessions and what have you, he was quite intrigued. And towards the end, he said, it's been really fascinating, our conversations, and thank you, I've enjoyed it. And he said, if someone, you should go on a government board and advise about this. And I sort of said, thank you for that. It's very kind of you. I said, however, I've already given thought to this, that if somebody came to me and said, Rodger, we've gathered that you seem to know a little bit about chronic health and its complexities and a fairly broad subject on that, and we'd like to invite you to sit on a think tank to advise how we move the National Health Service forwards and think about really long-term attitudes to healthcare. Would you be interested? And my answer to that was yes, on one condition. Oh yes, what's that condition? You give me a 150-year plan that no one can mess with. Oh, can't do that. Well, I'm not interested then. Well, why do you need 150 years? Because I need at least 3 to 5 generations, and I need you to provide and train all the staff to be good trauma-informed, not lip service trauma-informed, really be able to have this artistry, that doesn't operate on labels, that understands the complexity of it and understands that we're going to deal with education. We're going to provide free, good, trauma-informed therapeutic intervention for any parents that want it, so that they can break their own patterns and the cycle of the ACE scores that go from generation to generation. And it's not going to happen. All right? Doesn't mean we're not moving forwards with something, but that's potentially what it takes if we're really going to move healthcare. Because if we are going to prevent and not cure, and we know, how many of these conditions, I forget who it was that quoted, and certainly Gabor quotes this figure, but not of his own, that the number of diseases and disorders which are inevitably DNA hard-coded is about 1 in 10,000. And everything else is reactive to environment. Yeah.
Exactly. And I think they themselves, the government data itself suggests that by 2040, I think the 4 top conditions that are going to be breaking potentially the economy, at least in the UK, are all long-term conditions: chronic pain, diabetes, mental health issues. There was one other, I think, neurological condition, if I remember right. And these are the 4 big ticket items that's going to bankrupt it if we don't recognize what we can do for treating it in a more scalable, sustainable manner. But also, exactly as you put it, how do you change to make it more preventable? And I think what you outlined there, the 150-year plan, I like it. It is going to be idealistic and not really achievable, but it actually chimes with something that I was reading about a guy called Thomas Kuhn. He had talked about how revolutions happen and how paradigms shift. And he kind of says that it requires one generation. So for example, a lot of things that are right now almost set in stone in a medical school or in a healthcare school, when it is taught, there are people in their 50s and 60s who have really brought up on 20, 30 years of teaching one thing. Trying to get them to take on a new way of thinking, a new way of healthcare, a new way of doing things is going to be very challenging. So actually, he suggests that sometimes that generation has to really die out and the new generation then takes over. So revolutions and paradigms often take a few decades to sit in and get in. But what you'd have to do is the science, and it's something that you mentioned about, science not being fixed, but it is evolving, is that scientific revolution happens because of a series of cascading dissonances keep accumulating to the point that the scientific community at that point says the old way of doing, or the original way, or one way of doing it cannot be sustained in the face of so much new knowledge that has come through, that we finally must override this old knowledge, and then the new knowledge will be then the prevailing paradigm until something else comes along to supplant it as our understanding evolves. And I think we are at that stage now wherein we spend the last 40, 50, 60 years thinking that disease will be coded onto a gene and we'll find one drug or one surgery, one treatment. I think we are now in that phase of the last 15, 20 years where we've understood the importance of trauma, where we've understood that there's more going on when trauma occurs to our bodies, that there's more influence of the environment and lifestyle approaches. So I feel like you, I feel a bit hopeful that with the accumulated evidence that's coming from every direction about lifestyle medicine, about trauma, about prevention, about primary care and sustainability, maybe this is the opportunity now that scientific revolution will turn next now for a newer model to come. And I was thinking, well, if 150 years has to be shortened, then, or can be shortened, then we need something to actually fund and support and pay for some of these things we're talking about. And I think that's where I don't know whether the present economies have the money to actually fund that.
Well, the challenge that you've got there, and maybe let's not make the whole session about the finance and the funding of things, because
Creeps there, isn't it? Yes.
Well, we'll be here all afternoon, but and probably be none the wiser. But the challenge that any government faces, I believe, is that we have to continue to work in the repair it when it's broken model for a period of time, at the same time as injecting a huge amount of capital into a preventative model. And there's going to be a time lag between the drop off in one and the rise of the other. And so that's going to be a very expensive period of however many decades that will be. And so, I don't know where that funding is going to come from, but it needs a brave rethink for people to think about prevention and not cure. I was listening to a podcast recently, and my interest in the sort of the mind and body and the sort of psychotherapeutic body psychotherapy realm, and someone was saying, their daughter in its current time, their daughter is in a secondary school right now, and it was an all-girls school, and was talking about how her daughter had gone in with a bit too much makeup on or something, and that was not the school policy to wear any makeup, but girls being girls will always, and teenagers being teenagers, will try to push against rules. They are recalcitrant. That's what they are. And so it's going to happen. But what happened in this day and age was that the girl was brought to the teacher and said, take that makeup off now, and if you come with it on again, I will make you stand in front of the class and take it off in front of everybody. Now that's immense shame. And in the past, even those parental and educational models where we used shame in order to control people. And so the educational element for the prevention of healthcare, and shame, I believe, in my experience, I believe it to be the most damaging, painful emotion that humans can experience. Now there's healthy shame and unhealthy shame. Healthy shame does to a point when we feel something that goes, oh my goodness, I've done something that has hurt another person. Societally, that's really important for communities to exist. It stops us from, robbing people left, right, and centre.
Exactly.
It's important because we go, oh, something viscerally happens within me, and that may well be shame. But then there's the unhealthy shame, which is, you are bad for having a need, for wanting that, for having a particular desire, or for saying no, or for anything. Those are the things that we need to tackle, or to using shame as a manipulation tool in the way that I've just described. So, if we're going to tackle, and the consequence of shame on the human body, I can tell you is huge. It's vast. So, we haven't just got to fund the healthcare system, we've got to fund the educational system, we need to fund reform within parenting across the board. So I'm working through a book at the moment on the taboo of touch in psychotherapy, right? And
taboo of touch, meaning that for psychotherapists, touch is not something they should go into.
Well, for psychotherapists, actually, it's a professional boundary that, if crossed, could have them disciplined or struck off.
Wow, that's a real constraint that is put on them, isn't it?
And in my work with, last week I've just come back from assisting, the wonderful Aileen Lapierre with neuroaffective touch and the tuition of that, and I'm doing a sort of a further study with her and a sort of graduate certification program, and part of that is that we need to write a sort of dissertation or something. Because when I first spoke to Aileen, and she was really championing this, I sort of said, I don't really understand, Aileen. I don't understand what you mean there's a taboo of touch. I said, because I've been a I've been a touch therapist for 35 years. It's what I do. And she went, oh, well, that's interesting. And, you know, the work that we're doing is very much joining up body workers of some kind, and there were medics there, and the body workers and people from a physiological background, and then psychotherapists. And it was very interesting, you know, working with the psychotherapists, they're kind of like, oh, I don't know how to touch and I mustn't touch, and they're overcoming that. And then all the body workers are going, oh gosh, can I get involved in what the mind is saying? Can I, oh no, that's not. And it's really tricky thing in terms of scope of practice of going, well, is that your scope of practice and are you outside of that? And we must stick within that.
Yeah.
And the challenge that, you know, you and I have is around, well, people see you as a pain physician. They see me as a physiotherapist. What they don't realise is, you know, I've done many, many other things, and I am licensed to do a lot more than just physiotherapy. And in fact, physiotherapy is probably the lowest connected label that I might carry right now. These are things that are interesting to discuss, is like, if we're going to allow people to think more broadly and to be artists of their thing, then if we pigeonholed not only the diagnostic, but we've pigeonholed the clinicians,
yeah,
and saying what they can and cannot do, and where, oh no, that's the realm of psych. I'm not. No, we can't be everything. I can't have your skill and you can't have. But surely we've got to stop saying, well, we've got to have an MDT where, you know, you've got to have a nutritionist and a psychiatrist and I don't know.
I think that again comes to funding, isn't it? If you got to have a professional from each specialty, then you really are driving up the cost of any kind of care. But that's where their opportunity comes. You know, I like to talk about nutrition, and I think of that as a frontier that we need to be crossing, where every professional has some knowledge. You don't have to be a nutritionist. There is definitely a role for some patients to be seeing a nutritionist or a psychologist because they've got truly a pathology or a condition, and I'm careful about putting a diagnostic label, but something that requires real expertise, and appreciate that there may be certain forms of trauma, for example, which require expertise. But at the same time, there should be the role that every clinician at least feels comfortable doing. There's a scope of practice for every clinician wherein, for example, touch should be possible. Knowing what we know now about how the body allows for certain emotions to be processed, you'd have thought that someone who's a psychologist or a trauma therapist should be able to bring in some body-based approaches, at least at a lower level if possible. But I'm surprised to hear that that is almost considered taboo. A lot of my colleagues within my sort of medical field wouldn't even go down the route of anything psychological because they'll say, oh no, we didn't learn about that. We don't want to go there. I'm happy doing what I'm doing in my lane. I'm just going to refer to the psychologist. But that doesn't really help the patient because that just drives up one more bottleneck, one more wait list, one more waiting line. And that's why in some ways, within the pain side, and you must be aware of it as well, there's this concept of psychologically informed physiotherapy. So now there is the appreciation that physiotherapists should know enough about the patient, should be able to bring some basic psychological principles, and they can safely incorporate it into their practice without breaching scope.
Yes.
But you're right. I completely see the point there that we should have some transference of some common skills across all clinical specialties rather than pigeonholing. And that ends up at a societal level stereotyping our roles, wherein I've now qualified in lifestyle medicine. I can feel that I can talk about behavior change, about what exactly are commercial and social determinants of health, things that were not taught to me as a pain physician. So I have been able to expand my scope of practice. But if I start my conversation as I'm a consultant pain medicine, even now 99% of the people, including some of my closest friends, would say, ooh, can you lend me some cannabis or some medication? Right. Or can you give me a steroid injection? That's the only view they have of a consultant pain medicine, rather than everything else that I can bring to the table. And I think, I wish we could change that there. I'm trying to think how I can make calling myself something more mysterious so that it takes out the stereotype, or maybe not even give an introduction.
I know. I've done the same thing of going, what do I call myself? And you know, you don't want to give this long list of different disciplines because it's like, oh, all right, you know, but
show off,
yeah. But yeah, so what are we? You know, and every label is insufficient, and you know, at the end of the day, I'm just sort of, well, people go not to see Rodger Duckworth physiotherapist, but just, you know, if you want that, go and see a physio. But you come and see Deepak or you come and see Rodger. Yeah, what am I? Well, I'm Rodger, and you know, you meet me with a breadth of experiences with body psychotherapy, with somatic experiencing, with all sorts of disciplines.
What name would infuse both the art and the science together?
What would put the art and the science together?
That'd be interesting, isn't it?
It would be an interesting thing. As you're speaking, I'm remembering being at the trauma summit last September, October in Oxford, and Bessel van der Kolk was there, and he said, here's my take on things. Whenever you're working with somebody or you wish to work with somebody as a practitioner in the realm of trauma, yeah, make sure you find somebody who's done more than one thing.
A colleague, you mean, that who has done more than one thing?
No, what he's saying, as if you're a patient and you want to find someone to work with as a clinician, make sure you find someone who has done more than one thing. i.e., don't find someone who has just done Gestalt psychotherapy, or someone who has just done, you know,
a narrow field of expertise.
A narrow field of expertise. Our pain physician, our psychiatrist, our trauma-informed physiotherapist. What you want to find is somebody who has done. I'm seeing an IFS therapist. Okay, right. No one tool fixes all.
Yeah.
And so, you know, I often say, look, people say, what are you doing? I'd say, well, if I pressed pause and looked, I'm using 4 different modalities right now in this moment, in this session. I might be using somatic experiencing. I might be using some understanding of adult attachment repair. I might be using some neuroaffective touch, and I might be using some other form of psychotherapeutic modality, and I might be using other forms of you know, touch therapy, all combined in one session. And all of a sudden they might start talking about something, and I might feel like we're in parts work, and I'll go, okay, I'm using some parts work, some IFS type work, and I've heard other people speak about this, and I believe that this is what we need to do, is that we need, because you can't do 1,000 techniques, because then you can fall over yourself. But in the end, you know, when I'm teaching my peers and colleagues, I'll say, look, there must be many techniques, for in the end, there are none. And when we stop actually going, you know, people say to me, I was doing something on the teaching last week, and somebody was interested because I'd done Chinese acupuncture, and I said, yeah, but I don't stick needles in people anymore. And they were puzzled, and I said, they said, I don't understand. I said, well, catch me at lunchtime and I'll show you what I mean. So I did, and then I sort of stood off them, and I felt their energy body, and I could feel it, and I thought, oh, I can feel something here and here and here. And then I said, may I touch? Sure. Yes. And I put my hand on the back and put my hand somewhere down their arm, and after about 60 seconds they went, whoa, what's that? What's happening? What do you feel? Something's happening, moving in my body. Oof, right now I feel really emotional. What is that? And they went, how do you do that? And I said, I have no idea. Yeah. And I said, I don't mean that. I mean, I kind of do. I said,
but you're bringing in the benefit of few techniques at your disposal.
I'm bringing
and that's a new level of expertise, or a new level of understanding of the human body, isn't it? That is an art.
It's the art of the decades. And is that, you know, and I'm going, well, yes, Chinese medicine had something to do with that. Yes, the understanding from a physiological point of view and robust Western medical background, etc. Yes, an understanding. I've been a martial artist for 20 years, and I understand that. I've looked at, you know, other forms of energy medicine. I've looked at fascial work, and is it all of the...
Likely,
don't know,
yes.
don't care. And in the end, all that happens is I just go, for me, it's like a magnet. I'm drawn to something, I'm there, and then I'm in resonance with the person, and it's attunement, and it just starts to happen. And I remember, I'm saying that word, I'll shut up in a minute, but the attunement, I remember in one of our earlier discussions together, I used the word attunement, and your ears pricked up. And I'm now taken to this, and we're talking about touch in healing trauma and illness. Touch is a primitive thing. It's the number one thing. We are held in a womb in contact. We are then dealing with attachment and touch and repair of touch and attuned touch that says a parent knows somehow what the little one needs. And I believe that attunement, that the art, that there is no science or structure around that. It's called being a parent. It's being a human. And what we're trying to do is trying to do the same thing as external clinicians to attune to our patients and clients. To go, what is it right now that this body is speaking to us and saying that it needs?
Intuitively, when I hear you say that, it almost feels like we're almost looking at multiple levels. And I'm like, at that level, when you say that, I recognize that to be able to provide that kind of care, and if that is our sort of new model of healthcare for this generation, for the next couple of generations, till something better comes along, because that's what science is. If we wanted to even provide this kind of attuned care that you're talking about, for your accumulated knowledge to become, to
Widely
create a
available.
few more Rodgers like you, is actually an expensive process. By today's capitalistic economy that we're all unfortunately part of, it will require maybe layers. Maybe there are parts of it that you could do uniformly across so that many patients get it. But then ultimately, exactly as you say, for providing that kind of attuned care, it almost needs to be a one-to-one therapist person relationship, something that is predominantly or at some level face-to-face, because there is some work that happens, and very interesting. Yesterday, my mom was telling me about this concept of quantum physics and AI and all of these technologies. My nephew is very much into comp-sci and is now in the US trying to be one of these AI interested people.
It's not the kind of conversation I have with my mother, I can assure you.
But the reason
Quantum physics and AI, wow.
But the reason is that she mentioned about it because she's interested from an Indian perspective in the teachings of the Gita and of Vedanta. And there is now apparently at that level, quantum mechanics, quantum physics, AI, whatever the underlying principles, do talk about the fact that there's entanglement and resonance and energies that are very much possible to exist in multiple parallel states. And ancient Indian philosophy and probably a lot of Eastern philosophy also accepts that there are resonances and energies that are unifying us, and that there are things that are linking all humans. And the reason I bring these two parts is actually to bring it back to what you talked about, touch and relationships. And the way I also agree with you on that part is that we haven't understood as yet what the importance of the pheromones that we generate when we are doing touch, when we are close to each other.
Yes.
We do not have a full idea and appreciation of the science involved, even though our ancestors have figured out that there is meaning in them, but we haven't fully scientifically put it down to bed. So until that happens, trying to bring AI and thinking that technology will solve all of these fundamentally human attributes of attunement, of what the benefits of touch are, of what relationship building and meaning making is. I think that is where we need to find out. The science could be in providing to a larger population some of principles that can be around there. But I think art might very well be the fact that we accept that this is going to be an expensive or relatively smaller resource, but that we say is what's required when you want really good interaction, really good attunement. And if we want to move on, even in the space of lifestyle medicine that I'm trying to now put, and we talk about behavior change, I'm more accepting of the fact now that maybe I don't need to think about how I change an individual behavior, but if I can actually help create an ecosystem where processes all result in certain good behaviors that are encouraged, then maybe that would be the way to create attunement and relationships at a larger level than expecting everyone to be one and one on each other.
I don't think we can. At the end of the day, we can't. You cannot distill. I mean, that is the power of experience, and you cannot distill your experience or my experience into someone who's been qualified for 3 years. You can't do it, and so we have to accept that. But I think
that almost leads to layers, isn't it? There will be that group of people who have lesser experience out of their whichever healthcare school they come out from, who will need certain amount of training. But then what are the systems we can put in place so that if somebody wants to come to where you and I find ourselves, what could they do to shorten the time? Do you think that's possible at all? Can we shorten? Could any of what you've done over 3 decades be shortened?
Yes, and I try and do that actually. And I've just come away from doing some teaching with my colleagues, and with sort of myofascial approaches and lighter touch approaches to the body. And they're encouraging me to now put some teaching together to go out there and teach other people, physios, in this way. And I certainly have found over the years of teaching it more and more to colleagues that I'm able to distill it faster and bring in different elements. And I don't do things the way that I was taught to do them in any of those isolated ways. I think actually the first thing is getting the first obstacle is the mind. Actually, I think,
are they ready to?
Are people at a point of readiness of accepting and getting their own egos out of the way and dealing with the threat that sometimes if this is true, then that must mean or might mean that everything I think that I know might not be right. Now, for some people that's exciting, and for other people that's terrifying.
Absolutely.
And it's helping people do that, and then we get into early adopters, laggards, all that kind of stuff. Yeah. And so, what can we do? And I think the awareness, and it's one of the key things that we're doing this for, is to raise awareness and to move that forward. And more people are being aware. So I think if people are aware of it, and as you say,
stay curious as well.
Stay curious, and then being able to say, right, well, are there tools that we can train you in? Are there ways in which we can integrate? Because very often, where does one model overlap with another? And really, there are many forms of somatic therapy out there, and to an extent IFS is sort of has somatic elements, even though it's a very psychological model, but it's embodied. And I think the first obstacle is just saying to people, look, the mind and the body, and actually beautiful to hear you speaking there, that actually we're almost getting into the, dare I say, spiritual dimension here. And that's been a taboo. That's been a huge taboo.
Exactly.
To try and suggest that spirituality needed to exist within healthcare or in any way to do with human health. And that was just, that was an absolute taboo. There was no way you were going there. And yes, you're getting into the quantum physics realm, entanglement, etc. And is there science around that? And yes, pheromones. But I mentioned, I think there is some good science from, say, companies like HeartMath, and the fact that, well, probably our energetic field from our hearts is overlapping right now,
yeah,
and is communicating. And we look at the fascial system. I got some interesting statistics. I might be slightly off, so forgive me, anybody out there, if I misquote it, but it's in this order that the speed of transfer along a neuron is about something like 250 microseconds or something like that. And the speed, but now there's a communication that's been shown to occur through fascia, which is 125 million microseconds.
Much faster.
Much faster than any nervous system transfer at all. So it's almost the speed of light transfer through the fascial system from cell to cell as a communication mechanism. And then we start looking at the energetic fields and the chakras and all of the other energy things, which I've also studied along the way, and the fact that we can feel energies around people, the resonance of nervous systems. Gestalt psychotherapy talks about the field.
So you can bring all of those things in, is it?
In somatic experiencing, it would be talked about as resonance of going, whoa, I'm noticing my nervous system. It's like I've stilled my lake. You create a ripple. I go woo, 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 but I don't have to take it. I notice it and use it as, ooh, what just happened? I think you can distill a lot of that down because the commonalities, and you and I are both speaking at the EMDR chronic pain conference in a few months' time, in fact, a few weeks, not long now. I was asked to speak particularly in relation to my more sort of embodied and somatic work. And for me, I think the common ground, and as an EMDR therapist as well, the common ground I've found in any kind of trauma work is slow it down. Whether it's be EMDR, somatic experiencing, neuroaffective touch, IFS, other forms of psychology, somatic movement therapy, anything that's involved in that is about slowing down, my dominoes idea, slow it down so that you can catch when the dominoes and the disturbance in the system that's being not optimal. So I don't care how you do that. So in answer to your question of is there a way we can distill this? I think so. Have I got it sussed? No. I'm trying to put it together right now.
like most things in science, you can bring it down, but the art isn't actually deciding what's going to be the best fit, isn't it? And that's going to keep changing with each time you say this, each time you try to teach this, you will know probably
a bit better
what hits, what lands better, what flows easier. I think that is just the way.
So I think the awareness of the fact that the mind and the body and the spirit and being able to actually have a communication, I can't believe actually, here I am talking, sticking it out there to the globe. 15 years ago, I would not have talked publicly about, use the word spirit or energy in that way because, and even actually, but here you're up against professional bodies. My professional body, I used to be the chair of there was a subgroup within physiotherapy. It was the Energy Medicine Association, and that became disbanded. And the Chartered Society of Physiotherapy have now formally said that any form of therapy that has the word energy in it is not covered financially or insurance-wise, and is not to be part of.
That's still their stance, is it?
And they were more open about it in the past, and they have now shrunk to say we're not doing anything that constitutes energy medicine. That's not physiotherapy. So actually we're moving in the wrong direction, not the right direction, sadly.
That is
so I just have other insurances to license me to do that work instead of, so I have different insurances to cover me for different work.
It's the nature of today's society, isn't it? There's so much misinformation that there is a very thin line between somebody talking about something that is still yet to gather evidence. But I think it's what people end up doing. If you don't know something, it's better to fear it. And if you're fearing something, you might as well stamp it and refuse to recognize it, rather than be curious about it. I think it comes back to your point, can we just stay curious, be more aware, and maybe the new way of healthcare, that I think comes to the fact that isn't that at least there is a much more open acceptance that the mind and body are not separated anymore, that there is a complete unification, at least that's there, even though our healthcare systems still don't teach it that way. But I think in clinical practice, there's a lot more acceptance that these are indeed. I'm happy to say that actually there is now the possibility that there's going to be a British Association of Mind-Body Medicine.
Wow.
That's going to come through pretty soon, and we're going to have a lot more people accepting and interested and supporting that alongside whatever's happening in lifestyle medicine, trauma practices. Everybody talks about a trauma-informed society right now. All of those things which probably 5 or 10 years ago would be relatively fringe is now very much a mainstream discussion. Trauma dominates the conversation in the last 5-6 years in every field and space. So I think I'm hopeful of those parts, but we'll have to see. As you said, there are so many other small obstacles in the way of this becoming the new way healthcare to be practiced. I get a fair number of patients who get diagnosed with fibromyalgia coming to see me both on the NHS and privately. And invariably, when they have not been explained enough about the condition but just given a label either by a primary care practitioner or a rheumatologist, their first desire when they come to see me is actually to reject the diagnosis, partly because the appreciation is that fibromyalgia is somehow a diagnosis of exclusion, or they feel that it doesn't fit in with that. And typically, again, long COVID is something that for a period of time was often diagnosed quite a lot, and now because nobody's testing for it, we don't get the diagnosis happening much more often. And other conditions like chronic fatigue or ME, there are two parts here. One is at a societal level, people like to have sometimes a diagnosis that they like and that they can identify with, because it gives them at least a feeling that they've got something that they can explain to their family about. That's one part. The second part is, especially for conditions like long COVID and CFS, there is a strong sense of injustice that these patients feel, because over the last 20-30 years, they have been unfortunately put in the place wherein it's been predominantly classified as a psychological problem.
Yep.
I think we've got enough evidence now to say that it's somewhere in between. Probably there are biological elements going on, but the people who are stuck in either the mind or the body space, they don't want to move to this between space to say it could have elements of psychology and biology both involved in it. The way I tend to present it to most patients is to actually say, here's your nervous system, here's your immune system. These both are connected very strongly. And one of your videos that you talked about was the psychoneuroimmunoendocrinology, the PNIE system. I actually invoke that kind of example to actually say that if your immune system is looking out to protect you and looking out for threats, anything is considered a threat, even if it is a traumatic experience or an actual physical trauma. Both of it are threats, and that immune system is going to activate the nervous system to do the needful, and the nervous system is going to instruct the hormone system to put out the cortisol and adrenaline. And there you have this combination of symptoms that would be seen in long COVID, what we understand as long COVID, or is seen in what you understand as fibromyalgia. But ultimately, I kind of say that all of these conditions indicate a level of nervous and immune system abnormality. What can we do to calm the nervous and immune system down? Let's break it down to the level where both of us are willing to accept and agree. And I think in some way, this comes from work that has been done in other fields. So this is where I agree with you entirely on saying that if you come with only one field of expertise, then I would be finding it very difficult to explain and say what I'm doing now. But I'm staying curious and saying, okay, I've learned so much from my interactions with you, from my interactions with other psychologists, other fields, and from even completely entirely separate fields like knowledge management and industry, where they have this thing of when you're dealing with complex things, and if the human body is a complex system, and you have two people with differing views of things. So a person who's saying, I don't believe I have fibromyalgia, this label is something I don't believe in, versus here I'm saying, okay, I also am willing to understand that is not fibromyalgia, then I need to find a way to actually break down the condition. So what I'm doing is what is called as deterritorializing. So I break away the territories, break it down to the smallest part wherein the patient and me can agree, both of us, and then we build up something together which we both can stay in agreement and alignment with, and that allows for the rapport and for me to then put a menu of options which they might consider as treatments or management strategies, and that is a shared decision making. I think in my way, I feel that's true shared decision making in my head, because I've broken down the individual bits. Both of us agree that the nervous and immune system is under threat, and both of us agree that this is overprotection, and both of us agree that we must do something to reduce the overprotection and it's not required. And to be frank, up to now that part has worked fairly well, and that's the approach that I use clinically to try to explain this assortment of diagnostic labels. Now, coming to your question, maybe one of the sub-roots of your question is there a way that eventually all of this could have a common home, maybe a common name? I doubt it. I think there'll be a variety of reasons that will prevent it from having a common name. But I think, like you started this conversation, we have to meet the patients where they are. We have to meet people where they are and find the commonality from them and work and walk with them from there. And that, I think, is maybe the way we need to try. That's how I try to address this.
And that's the art too, is to be able to go, well, where are they? Because they come with all of their preconceived ideas of it's not my mind, or often beautiful mind-body dialogues that we might use in neuroaffective touch. If you get the mind saying one thing and being resistant, and the body saying, I was my first patient this morning, there were some beautiful, beautiful tears happening with this lady. As the mind, and I was saying, well, look, the mind was saying something, and then I was saying, how does body feel about that? And then she just cried, and she said, the body's trying to reach out, but the mind can't hear it. And it was so touching, and I said, is there any reason that the mind does not feel safe to hear what the body has to say? And then we went somewhere with that.
That's a beautiful question to ask. That's a nice, in sort of the coaching language, it's a perfect question that allows them to come up with their own explanations that would work for them, and
they were
the journey
able to discern between a somatic experience of language, and it has a different quality to it, of a more emotional quality, an embodied quality. Now we could argue whether that's psychologically two parts of the brain speaking, or is that two parts?
Is it relevant at all?
Don't care.
Yeah.
But it certainly has a different feel. But the resistances of our mind to, I can't give up control. I can't give up control because, why? Because if I do, it's terrifying, or it's going to bring me in contact with the felt sense in my body. Yeah, and the experience that we have, and I was just thinking, as you're speaking, this systems, and we dissect things quite literally as students, both of us, and then we compartmentalize the immune system, and then we think about how they communicate with one another, and yeah, even that in and of itself is a sort of, there are separations, and we've gone into the quantum realm wonderfully today, and there is this sense of instantaneous. There is, in the quantum realm, that the impact. Back to my expression of, is the water molecule separate from the ocean? Yes and no. But if that vibrates, every molecule in the entire ocean will feel it immediately. And energetically, spiritually, we're into consciousness, potentially, what you were talking about here. And then we're into the community of living, and all of the wisdoms of the great teachers of, be the change you wish to see in the world, from Gandhi,
I've got that as my DP line, yes.
All of those things All of those things, I think, are really important things for us to think about. And the body doesn't have a kind of necessary, if we almost don't think about them as separate things which are communicating one to another, but almost that there is a simultaneous, synergistic being that we are, and that we are a spiritual thing living a human existence, all of these wisdoms that come from the ancients. What if there isn't a set of systems which need to be compartmentalized, other than that there is an instantaneous, energetic, vibrating, communicating organism and set of systems, if you even dare to compartmentalize it that much?
True art. Is it feasible? I think we should try for it, but that is the true art of medicine, isn't it? To view the person every time rather than compartmentalize.